Hello, everyone. My name is Shayma Kazmi. I'm a thoracic medical oncologist at Cancer Treatment Centers of America. And I'm going to talk about a slightly different topic other than cancer. We're going to talk about the cancer physicians, preventing physician burnout, specifically as we talk about oncologists. So, in order to talk about burnout, I had to come up with some very creative slides, and just to get an agenda together made me start thinking about the historical perspective of burnout. So, we'll talk a little bit about how the term burnout even came about. I know that it's not the most popular term, with the idea that it may somehow blame the victim. There are other terms such as moral injury, but from just an understanding of everyone knows what burnout is, I think I'm going to use that term. We will talk about the prevalence of this problem as it applies to physicians. I know this is not something that we talk about a lot, or we have ever talked about during our medical school education or residency or fellowship. To my pleasant surprise, my medical students are now telling me that this is absolutely something that they are now beginning to talk about as early as in medical school. So there's hope for that. And in fact, as part of my Pennsylvania license renewal, part of the CME activity was relating to physician burnout. So the fact that this is becoming important to everyone is good. We need to talk about it in the context of the cost. Certainly, everyone pays attention when the bottom line for large corporations, hospital systems, and even government, at the end of the day, if it affects their bottom line, which is money and cost, we are going to get a lot more attention for this problem. But from our standpoint, what are our risk factors? What makes us prone to burnout? And what are these causes of burnout, and the warning signs we need to pay attention to? What are the ultimate consequences to us, to our patients, to the system as a whole, to our loved ones? And then we'll end with hopefully some tips in terms of how we have personal factors that we may be able to change and improve. Not to say that this is at all a personal problem alone. It is not really a personal problem, but there are ways we can react to the environment, to organizational pressures, to political pressures, to just a lot of outside factors that can be amenable to change. And certainly, how do we make that difference across an organization and even politically, if we're so inclined? And there are ways to perhaps do that as well. So we can't talk about physician burnout without talking about COVID-19. These are unprecedented times. The COVID-19 pandemic has placed an incredible amount of pressure on physicians. We are fighting for physical survival. We know so many physicians who have given their lives to COVID-19. We're fighting for a reputation amidst a political warfare. Today is, recording this on election day. So physicians as a whole are under attack with lots and lots of external pressures, and our bottom line, our income, our ability to earn a living has been dramatically affected by COVID-19. This is data from Medscape Oncology Compensation Report. And as you can see, this is actually a few months old, and I would say that these numbers are probably far worse now, especially since the pandemic is in no way contained. In fact, it's flaring up in 48 out of 50 states at the present moment. Practices reported a 55% decrease in revenue and a 60% decrease in patient volume on average since the beginning of this crisis. That's devastating to a lot of outpatient practices. Hospital and physician groups nationwide have implemented layoffs, furloughs, and pay cuts. For physicians primarily, um, who would have thought you go into medicine and you expect to really always have job security? You may not love everything about it, but job security is one thing that makes you go into medicine and gets you through. And that's no longer the case. 43,000 healthcare workers were laid off in March 2020. And that number has exponentially risen since then. 9% of independent medical practices report that they've closed their practices, at least temporarily, and some of them may not be able to survive this pandemic. And remote patient engagement has increased 225%. Now, you can look at this positively and say, hopefully, the advent of telehealth and the compensation for a physician's time on telehealth, if that continues, then that might be a positive after all, but we don't know this. This remains to be seen. So, what is it that really gets to us? We know what we love about medicine. Everybody knows that it's really patient care. We know that we like to take care of people. We love the gratification this brings to us. And that's why most of us went into medicine. But what do we not like? And so this is again part of that report, and this is a survey, and the rules and regulations, right? It's almost like every time you figure something out, it changes. It's almost intentional. And so these rules and regulations are complicated and they're constantly a moving target. So 22% of us hate that. And working with an EHR system, I'm surprised that's only 20%. But really, that is the bane of our existence these days. Every time you think you have something figured out on a system, they do what's called an upgrade, which, obviously is some sort of a downgrade. And you can't figure out how to master these systems because these systems were really not created in conjunction with physicians in mind. And it's evident in so many ways, and we're constantly trying to find a workaround to make them work for us. The purpose of these really expensive systems ought to be to make our lives easier, to help us spend more time with patients so that we can do what we do best, is provide clinical care and not type and not enter things and not click things. But that's really essentially these have turned into, and it's really really hard to pedal back, because really all everyone is adapting these, and none of these are very friendly. And difficulties getting fair reimbursement from dealing with Medicare and other insurers. Certainly, that's a constant fight. I'm always on the phone doing peer to peers. Often, the physicians or nurse practitioners or any medical provider I'm talking to with these insurance companies are not my peer. I'm a medical oncologist, and rarely do I get an actual medical oncologist on the phone. And really, it's so difficult to fight for your patients and spend all this time on the side just to get them what they need and what's appropriate, what is actually standard of care. These are not things we're doing that are sort of off label. That I can understand. The really basic care for these patients, we have to fight tooth and nail to get everything. And that's the essence of moral injury. Having to work long hours, well, yeah, that goes with the territory, right? Physicians are expected to work long hours. They expected to always care for patients at all times of the day and night. There was almost shame in my last practice that I was in if I didn't give out my cell phone number to the patients because, well, a couple of the partners did. Well, so are we not entitled to our own privacy, our own space, our own time when we're not on? And that's really a culture issue. Dealing with difficult patients, of course, in the world of Google MD, it's really, really difficult to talk to patients about what's appropriate care, and not necessarily what, there's well-meaning friend may have told them, or what a commercial may have told them, or because they want something because it sounded great. And you end up spending so much time at talking them off of inappropriate therapies and really talking about what they need, worrying about being sued. This is a litigious world that we live in, although for oncologists, it's not a huge, huge problem as it can be for some of the other physicians. So, what makes us so prone to burnout? Why isn't everyone else talking about burnout? Why aren't CEOs? Of course, I'm sure that some of them are burned out as well. They're very similar to us. We're type A personality people. So, if you read this ad, wanted medical staff, right? So, high academic achievers only, with strong perfectionist and self critical traits preferred. So, this is our problem. What traits define our success? What traits get us to where we are? are some of the very traits that set us up for burnout. So successful candidates will have had 5+ years training in party fueled student culture, followed by sleep deprivation and long hours in their 20s, regular exposure to death, loss, and human misfortune, never ending exams and lifelong study, constant onerous responsibility for other people's health and well being, strict hierarchical conservative training with a hint of bullying and intimidation, and easy access to pharmaceuticals. And we wonder why a lot of us are burned out. So, what is the problem? We, the healers, are sick, we are broken. And part of healing the healers involves really identifying what got us here. So, these positive values that make us who we are, that make us excellent physicians, that make us people that our parents are proud of, our families proud of, that we are proud of. What are these? Well, the idea of service. Most of us want to serve others. We want to make people feel better. We want to make them well. We want to be able to be of service to others. But what happens when the sense of service is overwhelming? Service at the expense of our own well being becomes self deprivation. So we are now servicing others at the expense of our own well being. And we feel that that is necessary for us to continue what we're doing. And the burnout factor of that is exhaustion. Cannot continue that level of service and self deprivation without being mentally and physically exhausted. What about the value of excellence? We are trained to be top of the class. We are trained to be excellent at everything we do. Gosh, if we're not perfect, patients are going to die. It's not an option, really, to not be excellent at what we do and how we provide healthcare. So, this drive for excellence can be a drive for perfection. I can't make any mistakes because there's no room for mistakes here. And this leads to a constant level of anxiety. The more patients that are on my schedule, the more EMR I have to enter, the more interruptions I have from my nurses and the infusion nurses, as well as the pharmacy. I am petrified. I'm going to make a mistake ordering chemotherapy. I'm going to make the wrong clinical call, which in hindsight may seem obvious. This leads to a state of anxiety, which only builds because we don't have the time to sit back, relax, and be confident. The sense of curative competence, right? We're doctors. We have to make patients better. That's really the goal. Can lead us to the sense of omnipotence and this overcommitment to our field of medicine, to our patients, and can really also lead to exhaustion. And of course, we're compassionate people. We are especially compassionate because we are dealing with sick, of really sick patients, most of whom are dying with terminal diseases. And this constant delivery of compassion leads to emotional isolation. Sometimes it's so exhausting to deliver that level of compassion every day. I come home and I don't have any compassion left for my children who might be throwing a tantrum because, it's not the dinner that they wanted. They wanted pizza and I made lasagna. So it seems so trivial. And I no longer have compassion for that kind of a tantrum and I have nothing else to give. It can lead to depersonalization and emotional isolation. Room to room to room, you go to patients, I call them 15-minute roller coasters. You go to one room and you're really celebrating with this patient because, gosh, their scans are good, their chemo is working, and they're elated and they're grateful and they're happy and there's tears of joy. And that right when you're out of that room and you want to be present in the room, but the person sitting next to them in the other room is someone who you're about to have a hospice conversation because their scans are terrible and they have no options left and they're not doing well. So you really have to turn that happy face off and then really, really care about the patient next door for the next 15, 30 minutes and then go back again and go to your routine, 3 to 6 month cancer follow-up patient who is doing fine and who might just be chatting with you about their next vacation. So It's a lot to turn off and on, room to room to room, and can really lead to emotional isolation. Very few people can understand what it is that we do. Now, this is a women's conference, and I really was exploring how burnout is different in women physicians. Well, the short and the long answer of this is even though women account for more than half of new medical school students, and there's increasingly larger number of practicing physicians that are women, there is absolutely not much information about gender related differences in physician burnout. But we know a few things. We know that women physicians differ from their male counterparts in certain things, and that may play a role in the rate of burnout. They may lack role models that are similar to them, female role models. They may face challenges of a dual career couple. And so, certainly, we know that in a dual career couple dynamic, the female still may bear the brunt of household responsibilities, of child rearing responsibilities. Certainly, there's always exceptions to that, but that's generally a stressful scenario. And you have to reconcile having only a finite number of years for childbearing. Let's face it. Biology doesn't care that you wanted to do a 10-year residency in neurosurgery. Um, Biology is biology. And so if you want to have children, you have to do it in the time of training, and you know how difficult that is. And that's just a challenge that women have to bear. We face lack of parity in salaries. This is not a surprise. And even now, there is a decrease in, even when you basically uh, equate the number of hours and specialties, there is still a decrease in female salaries compared to male salaries in the United States. We receive a lower number of promotions to leadership positions. This is absolutely a fact. But a lot of my colleagues that are going to speak today will talk about how they're changing that. And I'm really, really proud that they're going to be discussing this. We confront both conscious and unconscious biases, microaggressions on a daily basis, and we absolutely experience higher rates of sexual harassment. So, where did the term burnout come from? So, it was actually originally described in 1974 by psychologist Herbert Freudenberger. He observed emotional depletion and accompanying psychosomatic symptoms among his clinic's volunteer staff. He ran a free clinic for drug addicts. So he coined the phenomenon burnout. He borrowed the term from the drug addict slang. So he defined burnout as exhaustion resulting from excessive demands on energy, strength, or resources in the workplace, characterizing it by a set of symptoms including malaise, fatigue, frustration, cynicism, and inefficacy. In the following decade, Christina Maslach, so you must have heard of the Maslach Burnout Inventory Scale, she developed the model with three dimensions: emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. In 2018, a systematic review of 182 studies involving over 100,000 healthcare workers in 45 countries found 142 unique definitions of burnout. What this means is we don't exactly have a set criteria, a set definition. We intuitively know what this may be, but you have to really be careful in interpreting scales and percentages and prevalence estimates of burnout because it ranges widely from 0 on some scales to 80% on some scales. But in the past decade, a set of influential national studies of US physicians has found the burnout approximately ranges from 40 to 54%. And that's probably the most accurate number, which is huge. That's half the number of physicians treating us when we get sick. So this is an example of the Maslach burnout inventory. I don't know that you can read that on your screen, but emotional exhaustion is defined by I feel used up at the end of my workday. I feel like I'm at the end of my rope. I feel fatigued when I get up and have to face another day at the job. The sense of depersonalization is I really don't care what happens to some patients. It's not my problem. I'm over it. I worry this job is hardening me emotionally. When we no longer have the empathy in a hospice discussion, when we can get through it without getting choked up, that's depersonalization. This diminished sense of personal accomplishment. I don't think I'm positively influencing other people's lives anymore through my work. I don't feel like I'm as effective in caring for patients as I wish to be. This is happening to a lot of us. I guarantee you that you can relate to all three of these to some level. Even the World Health Organization has recognized burnout. 2019 burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And so WHO characterized it by three dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's jobs, and feeling of negativism and cynicism related to one's job, and reduced professional efficacy. Very similar to mass lack. So how big of a problem is this? We talked about this, about 47% of oncologists specifically experience some form of burnout, and this was a survey from 2017. Even oncology fellows have a burnout rate of 33%. So here's really just an approximate range of all other specialties. We are not the most burned out, but we're up there. We're absolutely up there. Critical care, neurology, family medicine, OB is certainly higher up on the scale. More worrisome is this idea and this understanding that the level of burnout is actually accelerating. More physicians are being burned out, and certainly we know this to be true. I mean, the pandemic has certainly accelerated this feeling, but more and more pressure from the government, rules and regulations, Medicare rules and regulations, more large hospital corporations buying out small practices, so less autonomy. You take a bunch of type A control freaks and then take away all of their control, and you have a problem. You have a problem of burnout, feeling inadequate, feeling ineffective. So, what are these symptoms of burnout? There's many. There are a few of them. Absenteeism. You know what? Not showing up for that morning tumor board. I don't really have to. I'm just not going to go today. It starts with something as simple as I'm sick of going to these meetings and not feel like showing up today. It's a lot easier not to show up, and they're, of course, virtual. Reduced job satisfaction. Most of us go into this for feeling of just that satisfaction of you making a difference, you're making someone's lives better. Decreased self-esteem, increased medical errors. Those certainly happen as we are doing so many things so fast with multiple interruptions, and we're tired. Insomnia, withdrawal and isolation, decreased productivity, anxiety and irritability. I was very, very irritable, and I was very, very cynical when I was going through this. And of course, there's still times that I do. Exhaustion, depression, suicidal thoughts. Let's not forget that on average, 400 physicians commit suicide in the United States a year. That's more than one a day. These are accomplished, intelligent people that have made a place in society, and yet they have resorted to end their lives because this is too much. And we are not talking enough about this. One of my acquaintances, who's a physician, committed suicide about a month ago. I did not know her well, but this has been weighing really heavily on my mind about what could have possibly pushed her over the edge. She has two young children, and it's unbearable to think of the pain that she could have been going through that none of us were aware of. Impaired concentration and attention, relationship difficulties at home and at work, excessive use of alcohol and other drugs, and feeling detached from peers, patients, family, and friends. And of course, that feeling of dread before you go to work, that's a big red flag. So, why should anyone care about the fact that we're burnt out? How often do you sort of get the sense of, well, you know what, you're a doctor, you're accomplished, you have a lot of rights in this organization, you get paid well, you should just shut up. You shouldn't complain about what's happening with you. So you get this feeling that we're not allowed to feel badly. You get this feeling that it's almost that, well, you should be able to fix this yourself, sense in most organizations, but they should start caring because physician burnout costs the healthcare industry between 2.6 and 6.3 billion dollars each year. And this was a new study published in the Annals of Internal Medicine. This baseline about 4.6 billion in costs is from turnover, reduced productivity, and other burnout related factors. The high levels of absenteeism, chronic work disability are also associated with this costs. And so burnout related impairments in care can also negatively affect the overall perception by patients of a hospital organization. Those dreaded patient surveys, satisfaction surveys can be affected, and those are now directly linked to payments. So the bottom line is this is expensive to the organizations, and everyone needs to start paying attention. So there's a constant tug of war between the demands of your job and the resources that are provided to you that can fulfill those demands. The job demands are excessive workload or schedules that we have no control over, poor staffing, administrative burdens in the middle of all of the clinical responsibilities. You have to have administrative responsibilities, and you may or may not get the appropriate amount of time to do all of this. And how is your workflow? Do you have any control over your workflow and the interruptions and the distractions? And then inadequate technology usability. If you have an EMR that is not very user friendly, how much help do you get to be able to use it properly? The time pressure and the less personal time certainly is a very big demand. And the moral distress of not being able to get things for your patients that you absolutely know that they need and deserve, because of just hoops that you have to jump through. And then patient factors, of course, the sicker the patient population, the constant exposure to death and dying is very unique to oncology. And it's absolutely a much different job demands than, say, if you were in pathology. What are our resources? Our meaning and purpose in work is the essence of who we are. It's some days it's the only thing that gets me through is that I know that I was meant to do this to take care of people with cancer. And that is the most important thing for most physicians. The organizational culture is very, very important. Is this a punitive culture that looks at a physician's burnout symptoms and penalizes them, writes them up? Or is this a culture that looks at this and says, wait a minute, something is wrong here. Let's understand what got us here and see if we can support that person to get well, to get better, and figure out what the issues are. Are there alignment of values and expectations? Do you have job control? Do you have flexibility? Do you have the ability that day at 3 o'clock to leave and go attend your daughter's recital? Or are you not able to do that? Do you have flexibility to say, hey, I'll make up those hours another day. I just need to leave on that day. And how much autonomy is something that you have, or is it taken away from you? What are the rewards of the job? Of course, the meaning and purpose. Does anybody recognize the amount of work that you're doing, or are you always just called in when there's a problem? Professional relationship and social supports. How much time do you have to spend time with your colleagues to see how they're doing? And of course, they want to be able to support you. You want to be able to support them, but do you have the time, or do you want to just get it done and go home because there's just so much work to do? And how good is your work life integration really? How are you really prioritizing life at the end of the day? So we know that physicians have historically higher than normal workload. It comes with the territory, right? That's the approach we trained with, and that's still the approach now. We work on average more than 52 hours a week. We take night calls that generally don't get compensated. We're doing work at home all the time. I'm doing notes at 9, 10 o'clock at night. I was doing them last night. And all of these have been found to correlate with higher levels of burnout because we're not actually shutting off and we're not actually detaching from work. The effects of high workload can be reduced by perception of greater meaning in his her work, greater control over logistics. So once we have the ability We are not afraid of work. We are not a group of people that are lazy by definition. I mean, look at all the training that got us here. So the idea isn't that we want to work less. The idea is that we want to have greater control over the logistics of work. For instance, I love seeing my patients back to back to back to back quickly at work and be able to leave earlier so I can see my children and then work on typing up my notes later on at night. That's my choice. I could sit there and do my notes till, wee hours of the evening. And if that's what works for you, great. But the fact that I have control over my logistics of my day makes everything so much more bearable. What about the sense of community with coworkers? Is there a supportive culture, or really just a culture that looks for fault in everyone? And that's something that's really, really important to cultivate properly. Increased expectations of productivity, decreased office visit times, increased electronic messages and queries. We know that the more you tie a physician's salary to productivity, the higher the rates of burnout. And this is very much linked. Increased CME and mock requirements performed. When do you do these, right? On nights and weekends, vacation time. Moral distress. Never underestimate the importance of this distress. That's the anguish we perceive when we no longer feel we're acting in accordance to our professional ethical values due to constraint or duress. Do no harm is the oath we all took. And when have to see patients in 10-minute, 15-minute slots, we have to rush through things. When we can't give them the care they need because of insurance mandates, even though they're medically inappropriate, this causes us a constant level of moral distress. It's death by 1,000 paper cuts. It causes us loneliness, distractions, interruptions, workflow. Those are very tough. Administrative burden. We talked about EHR documentation, pre-certs, peer-to-peer calls, insurance denials, and physician harassment by patients. Don't underestimate. I don't think that you're the only one who might have experienced this. This is getting to be a real issue. Most organizations will always go with, the customer is always right philosophy, and we really have to start standing up for ourselves and our rights to not be harassed by certain types of difficult patients. The resources we have, this meaning and purpose at work, the sense of calling that we have really needs to be cultivated because that's what's strongly associated with elevated levels of meaning in life and elevated satisfaction. The patient is what is keeping the doctor from falling further into burnout. The physician patient relationship and the desire for doctors to help their patients is the core of why physicians entered medicine, yet a gap is pushing them apart. Organizational culture and alignment. There is an increased risk of burnout, I said, when compensation is based on productivity, but that's happening everywhere. Poor relationship with peers and nursing staff also correlates with burnout. So I'm not all negative. I'm going to talk about what are some of the things that we can do. And there's two parts of this. There's the personal ones and there's the institutional ones. So again, by no means am I implying that we can deal with burnout by fixing us. Burnout is an external problem, absolutely. It's an environmental, organizational, political problem. But there are still things one can do within our own self to try to combat some of this. The most important of which is acknowledge it, recognize the signs, say, yes, I can relate to all of those. I feel I might have some of those signs. It does not make us weak to recognize the signs and say, hey, I might be burning out. And proactively plan your life purpose and vision. I'm going to talk about this in the next slide, but it really, really is something that most of us don't do actively or purposefully. We sort of passively live our lives, and I'm very guilty of that as well. We go day to day to day to day. It's like we're just getting through one day to next day to next day. Really, look back a little bit and plan, where is your life going? Is this where you want to be? Is this the purpose of your life? And what is your vision for the future? And don't underestimate the support group of your peers. The power at our institution, we established a physician forum about 3 years ago with 8 physicians that meet regularly. every 4 to 6 weeks and 4 hours at a time. And you'd say, gosh, who has time for that? Nobody has time for anything. The point is, you make time for things that make a difference in your life. And what wonderful breakthroughs have come through these peer support groups. I can't even list, but it's been life altering to really experience these support groups. Time management strategies. I mean, it sounds so cliche, we know how to manage time. We've been through residencies and fellowships and sleep deprivation. We know how to do this, right? Yeah, but now we have jobs and children and spouses and families and businesses and maybe other ventures that we're doing on the side and now we only still have 24 hours. So how do we prioritize our time? I have the problem of always saying yes to everyone, right? So you start out young in your career, you feel just a sense of, wow, they chose me for this committee. How can I say no? I'm going to say yes. Of course, I'm going to say yes. I want to look very eager. I want to look enthusiastic. I want to look like I'm a team player. And I said yes to everything. And then I realized I can't do everything. And so it's really, really important to not respond right away. One of the strategies I've used is when there's a request for me to do something, I don't respond right away. I say, you know what, that's sounds wonderful. Thank you so much for considering me. I need to review this and get back to you and let you know if I'm going to, take up this position in this committee. And really think about how it fits your personal goals for the future. And really think about what you're giving up to do that. And if it fits your agenda for life, absolutely go for it. And I've learned to say no. And I've learned to use the word bandwidth. I love that word. But just the ability to say, you know what, it's sort of not you, it's me. I don't know that I have the time to give to this important project. And say no in a way that you don't feel badly. And you'd be surprised. Most people move on to somebody else. Identify your triggers. These are different for everyone. What is it about the day that really gets you down, that gets you mad, that gets you frustrated, that makes you angry, that makes you not want to go back the next day? What is it? Is it the patient flow? Is it that you feel like you're doing everything? Is it that you're sick of dealing with the peer to peers? So identifying these triggers and saying, okay, I love these things, I hate these things. And what of those things that are triggering me during the day can I actually change? And really, what do I want to change and have a proactive plan? You know, we don't talk much about home life, and we should. I always sort of, through training, I was always told, don't talk about your family, don't talk about your children. Women get discriminated against enough as is. You don't want to bring in, the fact that you have other obligations. It makes you look like your obligation at work isn't 100%. And so I think that that culture really needs to change. We all have families, men, women included. Even if you didn't, you have outside activities, you have a life outside the hospital, outside the clinic. And what that life looks like. Are you 100% in charge of the home life because you're in a dual working family situation? How fairly are these tasks split up? So really, we started to have family meetings, and I really started to recruit my children, my husband, and everyone I can get to help me at home. So I'm not doing everything. Certainly, I have to also not reload the dishwasher after my husband reloads it because it's not perfect. But so I have to also make concessions. But at the end of the day, everyone needs to chip in. Outsource as much as you can afford. Don't, and if you don't derive pleasure from it, absolutely outsource. If you don't want to clean your house, pay someone to do it. If you love cleaning, if that's your therapy, by all means do it. I love cooking, so I'm never going to outsource that. Although I hate cleaning, so I will outsource that for sure. So these are things you need to think about. What are some of the things you're doing and somebody else could do for you? So you have more time with your family, you have more time to do things you love and really disconnect. This is so hard to disconnect from your emails. You're supposed to be responding at 1 in the morning because your CEO or CMO or CFO emailed you. No, you don't. disconnect. We are connected far too much in this world, and we really just need to take a break from that. Make time for fun. This is easier said than done, but it's really, really important. If the pandemic has done nothing else, is really made us reflect at time at home, time playing video games, time playing board games, time just sitting at home and playing with your dog, whatever it is. Make time for fun. So this is really the life purpose and vision I was referring to earlier. Look, sort of your work is very small piece of this pie, your vocational work and volunteer involvement. Gosh, we make that to be our entire life. What about your spiritual personal growth? Is that something that happens in the background, or do you want to put, some effort into that? What about your relational, romance, significance other, social and friends, recreational, hobbies and vacation? What about financial cash flow? Physicians are completely getting crushed in debt, in school debt, in physician loans. And we really sometimes get so mired in that debt, we can't see a way out of it. And that's a big reason for burnout. Now, if we had a way to get financially better educated, there are multiple online groups that help with that and creating alternate streams of cash flow. We won't feel as bound to our RVUs and our bonus payments. Maybe we design a life that we want, the life that we can afford. Family in your inner circle. What about your physical and health? We preach all day, exercise, eat well. How well are we doing that for ourselves? Do we really pay attention to that? And if you reflect, you realize there's a lot of work to be done on so many different parts of our lives. Now, I did promise the institutional strategies as well. So this idea of just culture development, I've started to read about this sense of non-punitive culture, a culture where if there's a problem and a physician is expressing signs and symptoms of burnout, be it anger, frustration, disengagement, how do you deal with that? Do you, take them to human resources and write them up? Or do you really work with them and create a plan so they can benefit as well as the organization? What is this? A mitigation program. There's actually mitigation programs that can be built that can deal with these situations. And we need to work on this. And this comes from physician leadership. Administrators can be great. Administrators can also not be in tune with what physicians are going through. So really physician leaders need to create such a program. There has to be an institutional impairment policy, again, which is not punitive. We have to find, state boards in all of this having to report physician impairment. It's so punitive that no physician wants to get help for mental health or drug addiction because it's just one of those things you worry about your entire career. And that's just really not fair. There has to be process improvements across the institution, and they have to really take the physician's recommendations. And really, we as a group have to regain our ability to delegate, our ability to have schedule flexibility, because at the end of the day, the amount of work is not the problem. It's really how much flexibility we have to do the work we would gladly do, and how much support we have to do that. And we really need to start learning negotiating skills. Really, most of my education, I never really learned how to negotiate a contract, how to negotiate through, getting into leadership positions. How do you do this well? How do you, in a culture where you're not supposed to toot your own horn, how are you supposed to outline all of what you bring to an organization? And how do you really, instead of having imposter syndrome, really talk about your accomplishments and get what you deserve? It's important to get routine peer and team feedback. So I think that this can become really, really important as long as it's constructive, to be able to see how we are being perceived, sometimes to be able to see things that we may not even know about how we conduct day-to-day activities. And there's always executive coaching options. So that's certainly very, very important. It can be expensive, though there's many, many female executive coaches out there. as well as, there could be group coaching options as well. So some of these offer CMEs, so use them up. But it can be a huge, huge benefit in this time. So I will end with strategies to mitigate gender bias and burnout. So this is important again, since it's a women's conference, I am focusing on women. The research community really needs to develop a consensus definition of burnout, right? And promote the use of standardized measures, whether that's the mass Slack burnout inventory or something else. And researchers and healthcare organizations should consistently include physician demographics in their assessments of physician wellness. In order to mitigate these gender-based differences in burnout, organizations need to develop interventions targeted at personal and institutional factors and really emphasizing the latter. The culture of medicine has to change to eliminate conscious and unconscious biases, gender discrimination, and sexual harassment. And healthcare institutions needs to prioritize the physical and mental health of all physicians, with specific tactics, employed for women physicians. So these are take home points. Burnout is a very serious problem. 1 in 2 chance you already suffer from it. Earlier recognition and diagnosis may lead to possible solutions. We need to work on organizational strategies to deal with burnout that are positive, not punitive. Medical education needs to start addressing this during training. And you don't have to quit medicine to tackle burnout. If you change nothing, nothing will change. Thank you.